Hi, my name is Jack Crow. I'm an aortic dissection survivor and I am an aortic athlete. Aortic athletes is a group of over 2,000 people with all manner of aortic disease and from all over the world who are looking to live their best lives through exercise. Uh, a couple of things before we get started here tonight. I want you to click like on this video below so it goes, AI takes it to our aortic community throughout the world. And I also want you to join Aortic Athletes and our sponsor, Aortic Hope, on Facebook, where you can get lots of peer-to-peer support. Aortic Athletes is about uh, peer-to-peer support for people with aortic disease, whether it's a dilation, an aneurysm in watch and wait, a person who's had an aneurysm that's been repaired, someone like me who's had dissection and is or in open heart surgeries, and is looking for safe ways to exercise to improve the quality of their life. Our second kind of pillar is about sound science. And that's what we're about here tonight, sharing the cutting edge research in a, let's call it an understudied area of aortic disease and exercise. And so our part of our goal is really to share the latest information with you. And then the third pillar is really advancing the science ourselves. And we're going to hear about an opportunity later to actually participate in some observational studies that are just getting started in our area. So we want to, aortic athletes are motivated to help the science develop. Now, before we get started, I want you to remember that tonight's presentation is for educational purposes only. No one in their right mind gets their medical, personal medical information from YouTube. But and that's because each of us is different. Some of us have syndromes, some of us don't. Some of us have family histories, some of us don't. Some of us have been stable for decades, and some of us are not stable at all. So you need to talk to your cardiologist about the exercise prescription, and maybe we're going to talk about that tonight. That's appropriate for you. So, and then as we get started here, I am so excited to introduce our two guests. Professor Mark Haikowski is on the faculty of the University of Alberta in sports cardiology. His research list is longer than both my arms. He is, and particularly in the area of aortic disease. He's going to talk about some real, true, cutting edge research that he just published around aortic wall thickness and measuring it during exercise for the first time. And then also we have Dr. Nate Molson. Nate is the medical director of vascular health at Vancouver General Hospital and is the assistant professor at the University of British Columbia in sports cardiology. And Professor Haikowski is also in the area of sports cardiology. So we're going to hear about these two new studies, the one about aortic wall strength, and the second that Dr. Molson will talk about on, I think to my knowledge, the very first study on people in watch and wait, people with aneurysms and endurance events. So we're really excited to hear about both these topics. So guys, I'll turn it over to you, and welcome to Aortic Athletes and Aortic Hope.
Great. Thanks so much for having us. Really excited for this.
Yeah, thanks very much, Jack. I hope you can see my slides.
Yeah, and just for identification, this is Professor Mark Haikowski, who's going to be speaking first.
Yes, thanks very much, Jack, and thanks for inviting two Canadians to speak to your group. Maybe that's the first you've had two Canucks, but I've done quite a bit of work with Nate, and it's a pleasure to speak with him. I'm going to spend the next 10 to 12 minutes just talking about a very unique study that Nate and I and my colleagues have just recently completed, where we've actually measured the aortic wall stress during exercise. And to the best of my knowledge, this is the first study ever to look at wall stress in individuals with thoracic aortic disease. So in the next slide, if I can get it to work here, there we go. So I'll talk a little bit about a wall stress, what it means. I won't go into the real hardcore biomechanics. I don't have enough time. And as Jack said, I think an important caveat for my talk is, again, the people listening, we know nothing about the material properties of your aorta. In fact, the individuals we've studied, we don't know the material properties of the aorta because the aorta is obviously intact. But we have some very unique, very novel techniques to measure the aortic wall thickness, the aortic diameter, and the stress on the aorta while you exercise. I'll briefly talk about some of the exercise recommendations for thoracic aortic disease, but these likely do not really aren't that relevant for aortic athletes because probably you're training a little harder maybe than what the guidelines suggest, but these are basically guidelines for people who are relatively sedentary and don't do too much activity. And then we'll talk about our study on the wall stress. So just as a brief background, not that everyone's going to be a biomechanist after this, but wall stress is really important. I'll tell you a couple of reasons why. Because when you measure wall stress, another important measure is something called maximal tensile strength. That's the maximal strength that an aorta can tolerate before it ruptures. So studies where researchers have taken aortic tissue when individuals are having aortic graft repair, and they take a little bit of the tissue where the graft will be, and you can actually stretch that tissue in various ways and measure its strength until it ruptures, and that's the maximal tensile strength. Why aortic wall stress is important is because that's the stress that the aorta will generate or tolerate until it reaches this rupture threshold. So we have something called Laplace law, which is just this funny little sign there on the left is just wall stress, and it's directly proportional to your arterial blood pressure, which hopefully everyone is monitoring regularly. And that's also multiplied by the size of your aorta, the diameter, which is routinely measured probably in everyone on this YouTube video. But what's not measured ever or rarely is the wall thickness. It's a little harder to measure, and it's just never really in cardiology, sport cardiology, ever been measured. But it's a really important metric because thicker walls will dissipate stress. So you might hear something called an aortic paradox, where smaller aortic diameters can rupture. Well, that's just because the material properties are such that they're not that favorable, and the wall's probably pretty thin. So it has a higher wall stress. So if you just take some of this basic math from, I hope I'm not getting everyone nervous now, but if you have a diameter of 3 centimeters, a wall thickness of 2 millimeters, a blood pressure of 130, the wall stress is about 130 kilopascals. So that's roughly what my wall stress hopefully is. But someone who's got a dilated aortic aneurysm, ascending aorta, it's 5.5 centimeters, 1 millimeter thickness at the same blood pressure, the wall stress is about fourfold higher. And again, beautiful study by Vorp and colleagues published, 23 years ago, where they actually had some ascending thoracic aortic aneurysmal tissue, and they can measure the stress, strain, and tensile strength. Roughly, it's somewhere around 1,200 kilopascals. So roughly, we kind of use that as the rupture threshold, but there'll be variability in that number. So it could be as low as 800, maybe 2,000. And again, because we don't know everyone's material properties, I don't know what the rupture threshold for everyone is, or even myself. But for individuals who don't have aneurysmal tissue, where there have been studies looking at the maximal tensile strength, it's about 1,800 kilopascals. So thoracic aortic aneurysms will rupture at a lower maximal wall stress. So we'll kind of keep that number in check when we show you some of the data that Nate and I published. So what's unique about our world is that we actually, if you ever had an MRI, you're asked to sit really quiet and don't move. Well, we actually exercise you in the magnet. Now, some of our studies with our heart patients and our breast cancer survivors, we take them to maximal exercise. But in aortopathy patients we've studied, we only go to low to moderate exercise because that's what the guidelines recommend. So it's really cool here because this is a stepper, and we want you to exercise in a magnet. And we're one of the few groups that can measure your heart function during exercise. And to my knowledge, the only group that's ever measured your wall stress while you exercise. So here's just a picture of our MRI. And again, here's a ascending thoracic aorta. Here on the left bottom is just aortic diameter that we can measure. And on the right side, we can measure your aortic wall thickness. So if we know the diameter, the wall thickness, we also measure arterial pressure while you exercise, we can measure your wall stress. And that's in fact what we did non-invasively while individuals exercised in the magnet. Really cool physiology, really cool imaging technology. This is from Iselbacher, where Nate trained at the Mass General, who was the first author, and you're probably familiar with these, because these are typically what the guidelines are. What I'll say right at the outset, and it's no fault of the guidelines, but these are based on expert opinion, not on physiology. Why? Because until our paper, no one's ever measured wall stress. But you're supposed to avoid intense isometric exercise or heavy lifting with a phase 4 really prolonged Valsalva, because when you release that valve, you get a marked pressure overload, and that's worrisome for potentially vulnerable people for aortic aneurysm rupture. What they also recommend, though, is that you exercise for about 30 to 60 minutes to sort of low to mild to moderate intensity. What that roughly means is 3 to 5 metabolic equivalents. So you listening to our talk are expending 1 MET. It's 3 mils of oxygen per kilogram body weight per minute. My MET level is a little bit higher because I'm speaking, but roughly 3 to 5 times your resting level of energy expenditure is what the guidelines suggest. Kind of a few limitations with that, but again, I do understand why globally for the whole sort of aortic population, why these guidelines are what they are, because for the most part, we don't know what everyone's wall stress is. So getting back to our study now that Nate and I recently published in American Journal of Physiology, is we had 14 individuals with we call thoracic aortic disease, but they had 8 of them had an unrepaired ascending thoracic aortic aneurysm, and 5 had aortic dissection, so post-dissection repair, 3 type A, 3 type B, and 1 was a type B who was unrepaired. So, and most of the patients in our group, though, and Jack had mentioned like syndromic, non-syndromic, heredity. Ours were mostly degenerative. So that's a different type of aortic patient maybe than like someone with a Loeys-Dietz or a Marfan. So caution is warranted when you interpret some of our data, because it's only relevant to the 14 people we studied and not necessarily relevant to everyone on this call. But at least it is a sort of first step of what's going on. This is just some of the data. You can actually go look at this journal article if you're interested. But basically, our individuals were close to 70 years of age, so were our controls. They're very well matched for body mass index, and our aortopic patients had typical cardiovascular risk factors that you expect. And to be in the study, you had to be well controlled on your blood pressure, so our participants were. We also measured, asked them their physical activity. The American College of Sports Medicine suggests that you do 150 minutes of moderate to vigorous physical moderate activity to 75 minutes of vigorous activity throughout the week. But again, for aerobic athletes, aortic athletes, you're obviously doing probably more than that. But if you're interested in exercise physiology, our aortopathy patients had lower peak power outputs, lower VO2 peak. When we look at absolute VO2 or index to your body mass, in fact, it was about 20% less than age predicted. This is really important because when we talk about the guidelines, 3 to 5 METs, I'll tell you why that's a little bit sometimes not fully the best exercise physiology prescription, because for some of our individuals, that's actually way too easy. But for a few of them, it was actually near maximum based on their VO2. So the highest ever recorded VO2 in an endurance athlete without an aortic disease is somewhere around 97 mils per kg. You need 18 mils per kg to walk up a flight of stairs, get your mail, carry groceries. So that's really important. We did take on day 1 our participants to maximal exercise. So on day 2, we knew what power output to take them in the magnet. But this is under supervision of our cardiologist or someone like Nate, who would be supervising. So we're very controlled in our VO2 max testing, but we do go to peak workloads. So here's some of our data. This is your VO2 peak is, again, I said 18 is the minimal threshold for independent living. 97 mils is the highest ever recorded in an athlete. Here's our age-matched controls, 11 of them. Here's our aortopathy patients. And this is all what I was sort of inferring, but maybe didn't articulate well, but hopefully we'll do it better here, is that in about 4 of our individuals, like their VO2 is around over 21, 22. So 3 to 5 METs would be actually very, very easy for them. But there was another third of our group, roughly, that 3 to 5 METs is actually near maximum. So that's why I'm saying you have to be careful with general guidelines, because for a number, a third, it's way too easy. A third, it's actually near max, not low to moderate. And our other third, it was probably bang on, okay? So not that everyone can get their VO2 measured, but that's how we prescribe exercise with our aortopathy patients. We actually measure their VO2 and their wall stress. Now, of course, you don't have the luxury to have that, but that's what we do in our lab and our research. This is just the determinants of wall stress at rest. So all our patients and our controls are well controlled for blood pressure. By virtue of the design of our study, our aortopathy patients had larger diameters in green. What's interesting is, though, our aortic patients had thicker walls at rest. And that's really interesting and great, because a thicker wall will dissipate more stress. So as a result, the wall stress was not different. Some individual variability in these circles in green for our aortopathy patients, but the wall stress wasn't different at rest. Now, if all you did is measure diameter and blood pressure, you couldn't measure wall stress. So wall thickness is really important because it's a determinant of Laplace law, but no one ever really measures it. Now, during exercise, we had rest in 3 stages, and those 3 stages are low and moderate activity levels. On A is our ascending aortic wall stress, B is descending aortic wall stress, and what you can see in yellow is our controls, green is our aortopathy patients, and this is mean value. So we average everyone as a group. These little lines above and below are just the variability in our measure. What you'll find is that at these workloads, there was no difference in wall stress between our aortic aneurysm or post-dissection patients grouped together as thoracic aortic disease and controls. More importantly, our highest wall stress on average is like 270. Remember, the threshold for maximal tensile strength based on VORP is almost 1,200 kilopascals. So these guidelines, although they're an expert opinion, are at least correct in that they're well below the rupture threshold. But again, I don't know what the material properties of everyone we've studied is, or anyone on this call, and the descending aortic wall stress is lower because the wall's a bit thicker. So I'll just show you one last slide, because when we look at the determinants of wall stress, people will say, well, that's great, Mark, but you didn't take them to a very high intensity. So if you look on the y-axis, this is aortic wall stress. On the x-axis is just your systolic blood pressure. And these little circles with different colors are wall thickness, from basically 0.2, and that is a very, very translucent and thin wall. Very, very worrisome for rupture. And then it gets a little thicker, 0.4, 0.6, 0.8, and I just did some mathematical modeling. And so my whole point is that what worries me is when you have, and just at the outset, I only used one diameter for this modeling, 5.2 centimeters. This red line is the maximal tensile strength. So again, not knowing who potentially would rupture, but when you start looking at biomechanics, when you start to worry is when blood pressure is very, very high, even in someone who's got relatively normal aortic wall thickness. When you have pressures of sort of 200, 220, 240, the wall stress is below the maximal tensile strength, but it's still almost 900 kilopascals. That's pretty high and a bit worrisome. But conversely, on the other side, so pressure loading at very high levels is bad, but wall thinning is also bad, because someone who's got a very thin translucent aortic wall at 0.2 and a systolic blood pressure of 100 is way below the rupture threshold. So that worries me. And in combination of a dilated aorta, under a pressure load and a thin wall, that could lead to catastrophic failure. So again, this just highlights that we often look at diameter, but you need to look at totality of pressure and wall thickness. But unfortunately, unless you're in one of our studies, that's not going to happen. But the reality is you could have, when they're measuring your aortic diameter in CT or MRI, they can very easily measure wall thickness. One thing I didn't say is in our hands, the diameter doesn't seem to change from rest to exercise, and neither does the wall thickness. So in theory, if you knew your wall thickness at rest and its diameter and multiplied that by your systolic blood pressure and exercise, you could estimate your aortic wall stress. It's just we don't know what value for each individual person is the rupture threshold. But in summary, cardiorespiratory fitness varies widely among individuals with thoracic aortic disease, and probably in the 2,000 individuals with your aortic group, it'll vary markedly. There is a limitation of doing exercise at one size fits all because we all have individual variability. In our hands, in the patients that we studied, very select, light to moderate exercise was well below the rupture threshold or maximal tensile strength. And what we really don't know in aortic athletes and aortic patients in general is what's the long-term effects of exercise on your aorta's remodeling. What I will say, though, is I'm a very big advocate of exercise because yes, your aortic wall stress will go up a little bit when you exercise, but for the 23 hours when you're not exercising, the favorable benefits of exercise on your vasculature, your cardiovascular, skeletal muscle health outweigh probably the risks of a little bit increase in wall stress during exercise, provided you don't have a very thin aorta. So my point is that after you exercise, the wall stress will be lower for 23 hours. So I love your model, don't quit, adapt. And that's what we do in our exercise physiology prescription. And Nate is a world leader in aortopathy in athletes and remodeling, and he'll continue the discussion next. So I'll probably pass it on to Nate now. I hope that's what you were wanting.
Yeah. And as Nate gets his screens going there, Mark, I think that video of dancing in the MRI could go on TikTok. I love the video.
Yeah, well, they're not dancing; they're doing stepping. So it is exercise, and we can get the cardiac output quite high. So the point is, we have mastered, and so have my colleagues in Leuven and Melbourne, how to exercise someone in a magnet instead of lying still. Because if you want to elicit stress, you got to stress somebody, and resting measures of wall stress just don't cut it.
No, perfect. Can you see my slides okay there, Jack?
Yeah.
Perfect. Yeah, I know. I think it's great to follow, and always a challenging act to follow Dr. Hakowski there. But that was great, and I've had the pleasure of collaborating with him on the study he discussed, and also on this study that I'm going to present as well, looking at really the progression of ascending aortic dimensions in masters endurance athletes. And so just a plug for those here in Canada, we have Canada's kind of, I like to say, premier sports cardiology program here in Vancouver. So anyone that's interested, feel free, they'll put the website there on the end of the slide, but feel free to reach out if you have questions around that. We do a lot involved in clinical assessment and research here in Vancouver, located on UBC campus here in Vancouver as well. And so for those that maybe when you hear the term sports cardiology, I like to take 2 seconds to say, it's more when you're looking for advice around, what to do with, you have an aortic disease and you say, okay, well, I would like to some more individualized assessment, really to discuss this with those that know what they're talking about. I'm sure many of you experience that there's a lot of variable advice out there. And so I would put a plug in that if you do have the opportunity to talk to a sports cardiologist, really that's what the specialty evolved for, is recognizing that there are a lot of patient athletes out there who really have questions around, okay, what if I'm doing this? What about this? How do I live my best life? And that's really one of the main goals of sports cardiology. I'll talk a little bit about today. One of the other kind of tenets of it is really understanding, what is exercise-induced cardiac changes or aortic changes, and is that pathology? Is that potentially physiology? And then also how it helps inform management for patients that have disease that want to continue to be quite active. I also say that, from my practice in particular, I actually work across the full spectrum. So I run our cardiac rehabilitation program. So I see a lot of patients when they've had their dissection, they've had aortic surgery, they're coming to me right after that, all the way through to those that get diagnosed with disease that are continuing or have been very high level athletes and want to continue to do that. So I see that whole spectrum of exercise and cardiovascular disease and aortopathy. And flavoring the paper today is really how we define this. And so in our study, we were looking at masters athletes. And so what is that from a sports cardiology or cardiology standpoint? So typically In the cardiology world, we use the cutoff of 35, and that's historical because when looking at prior studies after 35, typically we'd see a big spike in coronary artery disease or heart artery disease, and below 35 is really more inherited disease. So, while it may not be fully applicable to, say, the aortic population we're talking about, it's more historical, but that's what I'm referring to when I'm talking about masters versus younger athletes. Competitive, really, there's not a completely agreed upon definition, but I'd say this is from the guidelines, and it really is around intent of exercise more so than necessarily the vigorous versus moderate, because some sports may have different hemodynamic loads on that. But we still really refer to that as individual participating in organized or individual sport, really, that require regular competition against others, and place a premium on achievement and some form of systematic training. So you'll see that definition within the population I'm talking about as well. And then sports classification. So again, we spend a lot of time thinking about that in the sports cardiology world, or what are the different hemodynamic loads placed on by different sporting types. And in a simplistic fashion, we kind of break it down into, strength versus endurance. And this is, I think I like this figure a lot more than what used to exist from the sports cardiology guidelines. Well, it may make things a little bit muddier. I think that's just life, and that most of our activities don't necessarily fit one the other. A lot of them have a hybrid between the two. I think classically we think of things like endurance running as really being running being the predominant kind of endurance sport, where you're having an increased sustained cardiac output, versus weightlifting, where you have brief spikes in your blood pressure associated with that, and maybe not that more sustained response or the sustained stress on the system. And so the background to the study I'm going to talk about today, I had the pleasure of training in Boston with Tim Churchill and Aaron Pagish, and they really did some of the first work in this area. And I think Dr. Churchill has also presented on the channel about this. So I won't spend too much time on this paper. I think this really flavors why we did our study and what the kind of knowledge gaps that still exist in the space. And so they were really the first to show that when they did a cross-sectional, and cross-sectional means just looking at one point in time of a population of masters athletes without known disease, looking at doing echocardiograms or ultrasounds of their heart, that those in this rowing and running population that had actually been participating in endurance sport for at least 10 years, so a quite select population of high volume athletes, that a significant proportion, actually in this study, 21% of all of them had dilatation, and clinically significant dilatation of their aorta, either at the root of the sinus of Valsalva level, as you can see there on the diagram, or the ascending aortic level, which was significantly higher than what we would expect from the general population. And so this brought out the concept is it possible that the aorta may adapt to high volume, particularly endurance exercise over time, and some of this dilation actually may not be pathological, but may actually be a physiologic response to this exposure to high volume exercise. Now, I caution and say that, this still remains somewhat of a theory. This data does support that hypothesis, but I think there's still a lot of work that necessarily needs to be done. Not doing things like genetic testing or understanding all this, it's hard to, while they didn't have known disease, you can't say that some of these patients may have had some underlying pathology as well. And so I think there becomes a challenge on individual patient level, and we see that all the time in clinic, is determining whether or not there may be some component of exercise remodeling versus some underlying pathology. It doesn't just apply to the aorta. We see this all the time when we're dealing with other cardiac issues, cardiomyopathies, or heart dilatation as well. But what really has not existed is any sort of longitudinal follow-up of these patients with dilatation. This is not a patient population of dilatation, but this is another study that has been published looking at longitudinal follow-up of young athletes, particularly, and this is a select population of American-style football players, where they did echocardiograms every year from intake when they were around 18 over their continued participation in American-style football in college in Georgia. And they did show some degree, a statistically significant degree of dilation of their aorta. Now, this football has a specific set of hemodynamic responses with that, a lot more weightlifting. There's differences by position as well. But notably for this study, there weren't a dilated population at baseline, and none of the athletes actually reached that kind of clinically significant dilatation level of 40 millimeters. So that brings us to the study in question today. So really the natural history of change in aortic dimensions in masters athletes, again, those over 35, who continued exercise exposure remains unknown. And there's clinical concern, understandably, that increased hemodynamic load of continued high volume exercise may potentially accelerate aortic dilatation. And this expert opinion or hypothesis has underpinned some of the expert recommendations in the past and some that still exist to avoid that for those that have some degree of aortic dilatation. And so this is the study today that we recently published in JACC Advances, Progression of Ascending Aortic Dimensions in Masters Endurance Athletes. I think it's important to kind of understand where this population came from and some of the limitations, though. So we have a large study that's been going on now for over 10 years called the Masters Athlete Screening Study. It's a longitudinal observation study of Masters athletes who underwent some cardiovascular screening through our center from back in 2015 through to February 2021, and have continued ongoing follow-up since that time. There's actually almost 800 athletes enrolled in this study with the mean age of 55 on intake. And so we were able to, because we have this data going back that time, we were able to do a retrospective cohort analysis to evaluate those patients that we knew had some degree of dilatation at baseline versus those that didn't, where they had more than one clinically indicated echocardiogram, so ultrasound of the heart, so we could actually see what the changes in their aorta was over the study observational period. And one of the strengths of the study is we actually had quite detailed exercise data on this population over the span of the 10 years of the study going so far. Now, all of it is self-reported, which has its own limitations, but we do have that at multiple time points, actually every year for 5 years, and then follow up at the 10-year mark. For this specific study, though, I know as I think it's important to kind of comment that we were specifically looking similar to Churchill's paper or Tim Churchill's paper, that excluding those with known aortopathies or bicuspid aortic valves, associated aortopathy. We can happy to talk about that in the discussion, but really trying to hone in on those that may have dilatation that was unexplained, whether or not this was related to exercise or potentially just an unexplained cause, but did not include those that had known syndromic associated aortopathies. So of that 798, this study really looked at the 50 athletes that met the inclusion criteria that had this multiple serial imaging. So again, that was not it's a retrospective kind of taking advantage of this study. So it wasn't an a priori goal of the observational cohort. So unfortunately don't have data on all of the athletes. And as I mentioned before, I think just for context, about 60% of them were recreational athletes by the definition of intent, and 40% were competitive or elite. And elite was competing at the provincial, national, or professional level in their sport of choice. And so of this population with multiple serial echocardiograms, 38% or 19 had evidence of aortic dilatation at baseline, so more than 40 millimeters, and 31 did not. And so, but as you can see here, the exercise volumes across both the dilated and the non-dilated group were actually quite high. This is predominantly endurance-based exercise. Being a good Canadian study, there was a reasonable portion of beer league and competitive hockey players, but there was also quite running and cycling as well. And just for context, and you may see these in other studies, I think it's always important we use these metrics around what exercise means and just trying to put it, it's not perfect, but put it into terms that we can understand. I think Mark nicely laid out what a MET is here, so I won't get into that. But when we talk about moderate to vigorous intensity activity, we can kind of characterize it based on METs. Now, there's some limitations for that, but for the purposes of this, 3 to 6 METs is about moderate intensity activity, and vigorous intensity considered over 6. So when we talk about MET hours per week, anyone doing over 30 is really considered doing high volume endurance training. And so I'm going to go back there and just kind of show again the volumes that were self-reported for this study. Like they at year 1, on average for these 50 athletes, it was 81. So doing significantly higher for what you'd think, and they're actually quite active over time. So year 5, it actually increased on average. And then by year 10, a little bit lower, but again, still above that 30 threshold. So I highlight that because it really is, I think, a strength of the study is we have that data to show that they continue to participate in high volume endurance training with that aortic dilatation. And so what was the primary finding for this study? So you can see here in red, those are those that had dilatation at baseline, so above 40 millimeters, and in blue, those are the below 40 millimeters. And so there was progression over time on an average of, now the observational period was 10 years, but on average between at least the two studies was about 5 years, give or take. So we say an average of 5-year follow-up for here with those continued endurance participation, is that there was no difference between those that had a dilated versus a non-dilated aorta at baseline and continued progression. Now, it doesn't mean they didn't progress. As you can see that there was some numeric progression in terms of both at the sinus of Valsalva and at the proximal ascending aorta. But compared to those that had a non-dilated aorta at baseline, there was no statistical difference between the two. And so that was really the main finding, one of the first observational studies to look at that. So in summary, there was really no significant difference in the rate of change in aortic dimensions between the masters athletes with aortic dilatation and the non-dilated group. The observed rate of change of masters athletes with aortic dilatation was 0.2 millimeters per year at the sinus of Valsalva level and 0.5, so a little bit higher at the ascending aorta level, again with relatively limited numbers, but well below what we would consider clinically significant or rapid dilatation levels regardless. One thing we did note, which I think is always important to highlight, is hypertension was more common, and even they were in the study, they were treated. Their blood pressures on average were still higher in the masters athletes with aortic dilatation as compared to those without across the study and even on medications. And so I think that just another point where just always making sure that those risk factors are optimized, and was a potential confounder in terms of the cause of their aortic degree of their aortic dilatation at baseline. So I think it's an exciting study, and we're glad that it gets out there to help kind of with hypothesis generation around the continued participation in sports for those that have some degree of aortic dilatation. I do caution and like to highlight the limitations, though. It means a highly select population. It wasn't our really a priori goal to look at this. We just used the study population we had, relatively small sample size, and we don't have any non-athlete or non-exercising controls for this, which I think should be for future work. So I would say it's caution and is required in extrapolating these beyond the study population, and definitely do need to study this further. But I do think it is really one of the first pieces of work that helps to support. These are the newest sports cardiology guidelines and they have a specific section, which I think is great, on those masters athletes that have some degree of thoracic aortic dilatation that's unexplained. And so that's really, I think, to highlight that, we see this in clinical practice all the time. And so what the recommendations should be, and I think this is a change from prior recommendations where competitive endurance sports below 45 millimeters still remain reasonable, and at 45 to 49 can be considered with a shared decision-making process. And again, just highlighting the need for individual approaches to it. But our data would support these recommendations that just came out earlier this year. Oh, I guess actually now it's 2026, so in 2025. So yeah, thank you for the opportunity to do that. And again, anyone who's interested in our website and our work, please feel free to check out our website there, Sports Cardiology BC. So looking forward to the discussion.
All right. Well, thank you. That was a feast. It was a lot too. And at the meta level, the news for people in the aortic community seems to be good, that we're beginning to get some data or information about, let's call it moderate aerobic activity. Other folks like Dr. Siddharth Prakash and others have done some work on moderate aerobic activity, and that seems to be getting more of the green light. I'm wondering though, the usual measures folks hear from their doctors are around maximum heart rates, and sometimes around, don't let your blood pressure exceed 160 systolic, but God knows how you would actually measure that during exercise and, when you're out in the wilderness on a run. So Professor Haikowski, could you talk about is there a correlation between heart rate, blood pressure, wall thickness, or is it genetics is all destiny and it just is what it is, and the rest of this, the blood pressure and heart rate is irrelevant?
Well, it's a great question. I mean, the heart rate is going to be really relative to the workload that you're doing. So, so as you're increasing the power output or your oxygen uptake, it's going to be quite linearly related. But many of the people on this call might be beta blocked, potentially. So that's one thing you got to take into consideration, because you may have a blunted heart rate reserve to exercise. So sometimes we'll be looking at sort of a perceived exertion, but what I didn't show, and you asked a really good question. We kind of coined this term aortic mechanical efficiency. It's probably not, biomechanisms probably have not really been in agreement with sort of the way we've measured it. But what I didn't show, as I said, is that the wall stress per workload, or what we did find is that at any given workload, the wall stress was a little bit higher than the controls. Now, that wasn't significant, but although the wall stress at any workload that was low to moderate wasn't different, at some at same power outputs, we did see, relative to your cardiac output or stroke volume, that's how much. See, what the aorta does, it plays catch with the aorta plays catch with the stroke volume that comes out of the heart. You eject blood out, the aorta will sort of stretch a bit, and then it'll recoil. So it's just playing catch with the heart throughout the cardiac cycle. So when we indexed wall stress to cardiac output, that slope was a little bit higher. We're not really sure what that means per se, but we did find that for some people, relative to what was coming out of their heart, the wall stress was higher. So that's kind of interesting, because maybe that might be a metric for future potentially dissection. I don't know. But I have to be careful, because we have the luxury of measuring your wall stress, and we prescribe exercise and wall stress. But everyone in this call doesn't have that luxury. So Nate can probably highlight better with respect to systolic blood pressure, but we often just kind of look at the blood pressure during exercise and see where people's ventilatory threshold is, and see how hard they're working and use their perceived exertion. But systolic blood pressure is definitely an important metric, because, as I said, in our hands, the wall doesn't thicken very much during exercise compared to rest, or the diameter doesn't change too much. So really what's driving wall stress is probably blood pressure. So that would reinforce that, caution is warranted with very high blood pressures, because that does increase your stress.
Well, Dr. Molson, Professor Haikowski talked about perceived exertion. Sometimes we call it like, can I carry on a conversation while I'm running? Is something like that. Do you think that does it make a difference if we're doing that for 20 minutes, an hour, or 7 hours of activity?
In terms of the effect on the degree
your
of
blood pressure and
Yeah, so I think the one thing, and maybe I'll jump if I can pick up on what Mark mentioned there as well, is I think one of the challenges exactly is, so, and it ties into your question as well, is how do we prescribe exercise when you ask those questions? And so how do we get into that in terms of blood pressure? And I think what happens a lot of the time is, the standard clinical exercise tests are done in a certain way. And a lot of the time the blood pressure response will be different during that than it will in real life. And so I do think, trying to do, if you have the opportunity, even if you can't do wall stress measurements per se, which I think maybe in the future that'd be great, but doing things like cardiopulmonary exercise testing, individualized exercise testing with your sport of choice. So if you're a cyclist and you run, like, there are differences in your blood pressure you're going to see there. And if you get told, and when people are giving you a heart rate, just keep your heart rate below this, a lot of the time, the reason they're saying that is they'll do the stress test and they will see what your blood pressure is. And when your blood pressure hits a certain heart rate, they will then use the heart rate as a surrogate to say, okay, well, when you get to this workload, this heart rate means that you shouldn't go higher than that, because we're going to assume that your blood pressure is that when you're exercising like this. There's a lot of assumptions there, and we know from exercise physiology that if you different sporting activities are going to have different responses between cycling, rowing, swimming, whatever it is. So that if you do get the opportunity to say, if you're a cyclist, do a bike exercise test, do a cardiopulmonary exercise test, see what that's like, and you can get a better sense of what your blood pressure is like during those tests. Now, that isn't necessarily available to everybody, but if that it is a possibility, that's going to allow you for a little bit more individualized exercise prescription. And what your question around the duration there, I suspect it probably is like in the terms of what we're talking about here, the degree of potential aortic remodeling with exercise, or it to the extent that we think that exists. Given the fact that we're usually looking at, like for example, in Tim Churchill's paper, it was patients that have been doing 10 years of exercise or more. And in ours, it was still those who are doing high volume exercise where we saw this progression. Is I do think that it is time dependent. And so you're going to have to, you might see some higher degrees of dilation from the concept of a physiologic response to it based on the duration over time. So it's not any given like one session of its hours. It's really more that cumulative exposure, probably over years. And I'm extrapolating a little bit because we see that in other areas of cardiovascular physiology. So with like LV chamber sizes, the larger the exposure to the actual volume stress being the time plus the intensity, then you start to see the higher degrees of remodeling. And so my suspicion is that's probably what we're seeing with the aorta as well. But again, that's my more hypothesis than actual hard evidence at this point.
I'm 5 out of 6 of my siblings all have aortic disease, and I'm the only Ironman triathlete amongst them. So they, of course, think that well, that's what must have caused it, as opposed to genetics. But hey, I noticed in one of the studies that the patient group could have up to 140 systolic over 90. I think that was resting blood pressure. In our group, aortic athletes, we always tend to talk about setting a goal at rest of 120 over 80. What do you guys see as a reasonable goal, and does it change at all for people who are going to be a little athletic? And for many of those folks, they might be raising their blood pressure up while they're exerting themselves.
Yeah, I mean, I think 120 over 80 would still be the kind of the guideline recommendation at rest. I would strongly encourage, like that would be, and that's just the best evidence for controlling progression of dilation over time, particularly in those that have high blood pressure. It's a little different though and I think that was nicely outlined by Mark with the study there, that blood pressure is going to increase with exercise, but that the 23 hours of exercise for an hour afterwards, that's very well established that actually helps to control the blood pressure and reduce that increased blood pressure during those other hours. So it's really finding that balance. The blood pressure is going to go up during exercise. We don't want it to go up too much to avoid the increased risk of potential complications, but that also helps to treat the blood pressure during the other 23 hours or 22 hours, whenever time you're not exercising. So, and just from a practical standpoint, a lot of times if you are exercising for longer durations, trying to be more intense, with doing if you're doing Ironmans, you're not just doing 1 hour a day, you're doing multiple hours a day. And so that can be a little challenged, and working with your doctor around the right medications, because some of these medications will, if you start to get dehydrated, if you're all those things, they can actually cause some symptoms. And so making sure though that you're not, saying, oh, I'm not going to take the medication because it caused this problem, just making sure you're working and being on the right medications. So in the sports cardiology world, we actually work with maybe there's a whole host of options for antihypertensives or blood pressure meds, but there are certain ones that are better tolerated by those that want to be athletic. And so we try to focus on using those when we can, just so it just helps to really improve compliance, improve outcomes, and also really make you feel better with exercise. Yeah.
And Mark, as you look ahead to, you've done this kind of groundbreaking study on aortic wall stress. As you look ahead to higher aerobic exertion levels, and then what about physical exertion? We have our crazy weightlifters. They want to lift big and they want to lift heavy, and our don't quit adapt motto really applies to them. Don't doing Valsalva, don't lift to exhaustion, high rep, lower weights. What do you think is going to happen to wall stress if you had studied, let's say, exertion more than aerobic?
Great question. We'll invite us back in a year from now, because we have made a knee extension ergometer that. Now, remember, we're in the magnet, so it's really hard, but we've designed an ergometer that looks like a weight extension, knee extension stack. So we will be looking at that in the next year. Nate and I will have gotten some funding. So now, remember, it's supine, it's a knee extension, it's not a squat where you're lifting 600 pounds. It is so very, very select, but we will do some dynamic resistance exercise at higher intensities and measure the wall stress. I didn't show this. We have something in review right now where we did some hand grip. Now, hand grip isn't weightlifting, but I can tell you the wall stress during hand grip again was very similar to what we were seeing with dynamic. But it's just hand grip, so that's not weightlifting. I can't say about aortopathy patients, but we published a paper 30 years ago where we measured the wall stress in the heart when you lift 1,000 pounds, and the wall stress wasn't that high relative to rest. But we have to be careful if you translate that into aortic patients and aortopathy. Kind of our motto is do what comes naturally, but not for too long. But the reason why lifting very heavy or doing a Valsalva is not something you want to do, because when you do a very forceful Valsalva, like 10, 15 seconds, or like you're constipated, or what happens is there's various changes in blood pressure throughout the Valsalva. But when you release the Valsalva, you get this marked pressure overload, and the aorta sees that high pressure. So those guidelines are correct, but so it's I'm hesitant to answer that because it's not, we haven't measured it. So until we can measure it, I'm hesitant to give you an answer because I could kind of maybe say what I think is going to happen, but what I don't know is, again, what I keep saying is the material properties of everyone's aorta, including mine. So, right, someone who's got a very thin aorta and it's dilated, a blood pressure of 110 at rest is a very high wall stress, right? So it's all really dependent. But we're taking baby steps. So we only went light to moderate. Now we've got the data. We hope to get some Marfan patients in, some Louis Dietz, right? Some syndromic individuals. But we still have to go what the guidelines say before we go to a bit higher. So we're walking before we run. So I'm happy to come back in the future where we will measure it. But I can honestly say, just to get wall thickness during exercise has been, so it's 2 years worth of work that we've done. It's not easy to do. A limitation that we've done as well is we don't have you in the magnet who does Ironman for 7 hours. We did 4 to 5 minutes at each workload, take a break, the next workload. We don't know what happens when you go 7 hours, but we know that hearts fatigue in elite athletes with triathlon Ironman. So that will have an effect on the aorta as well. So again, limitations, and I hate to say I don't know and I don't want to speculate, but I don't know and I don't want to speculate. But well, you know what the reality is, people are going to do what they want to do. And as Nate said, there's shared decision making with people, with their physicians. It's like, listen, I don't want to sit for the rest of my life. So I think you have to have those decisions with your physician, cardiologist, sport cardiologist. But we don't know. But we've thought about these things, and we'll test them soon.
And we've heard anecdotal stories from people who surgeons said during surgery, man, that wall was really thin. We got there just in time to do the surgery. So that's the thing. But I'm wondering, I think there's data that most people dissect. I think we know this, but I'm not sure, at rest or while sleeping. And so do we even know the role exertion is playing if it seems that most people are not exerting when they dissect? And that I think also that Dr. Molson, that sudden death by dissection is an extraordinarily rare thing. Is that so?
So, yes, so I guess the two pieces there I would caveat that with in young athletes. So I mean, in the sudden death concept is that it's when we look at what young competitive athletes, so those less than 35, we've done some work in that space, that aortic disease is relatively an uncommon cause of that. It does happen, but it is less common than other inherited disease. Now, there's some issues with that in the sense that it's not as common as some of the other inherited cardiomyopathies or things along those lines when we look at kind of larger populations of young competitive athletes. So what we don't have is great data on taking a population of younger patients or masters athletes with aortic disease when they have continued to exercise in large enough numbers to know those types of outcomes. To say what they've done in some other cardiac populations is been able to look at larger populations of, say, with X disease and look at those that are doing vigorous versus non-vigorous activity over longer periods of time and power that enough to look at outcomes. And so in the future, that might be something that can be done. I think that, it's great to start with the smaller observational data sets. I think what you mentioned before at the beginning, but that would be the kind of the better study to be able to answer that question. But you're right. And it's the same with a lot of conditions, is that exercise may increase the instantaneous absolute risk to some degree, but you're not exercising most of the day, and events still happen outside of exercise. And so that's when I'm talking to patients about the uncertainty around this with any condition, with aortic disease or other cardiovascular conditions, is that there's benefits to exercise. There may be some degree of risk. That risk is very hard to quantify with that for the exercise at that time frame during it. And that we just don't know in a lot of cases. And so what we end up being is that a lot of the times, because you're not exercising most of the day, those events still happen outside of it, but they can happen with exercise. And so then that's been studied as well, where they look at different events can happen with exercise. There probably is some degree of increased risk in certain patients for events happening with exercise. We just don't have the data to say, okay, well, what is that number to help patients make a decision around, am I willing to take this risk? Because we just can't quantify it on an individual level enough to really make it like more meaningful than what I'm saying here, where there's probably some degree of risk. I may say I don't think it's prohibitive to do the types of activity you are, or I may say, that type of activity might not be what I would suggest, but a lot of the time that still remains quite expert opinion.
Let's do some quick questions from aortic athletes in our remaining minutes here. Shar, aortic athlete Shar says, for watch and wait, what does science say about planks and sit-ups, if anything?
Just made me, I don't think I've ever done a plank, Nate, so up to you. I guess one thing is this,
we have lots of yoga aortic athletes, and they're moving in and out and breathe, a lot of breath. They're breathing through it. They start slow and they build up over time. Dr. Molson, what do you think?
That's oh, sorry, Nate.
No, go ahead.
That's sort of favorable, that type of. So John Lifter-Addis at Yale, who's done probably all the seminal work on aortopathy, there is an association between sudden surges in blood pressure, i.e. potentially heavy lifting, or even emotion, like very severe emotions, right? Stress, because you get a sympathetic surge. You get a marked increase in blood pressure. But planks where you're holding your breath for 5 minutes, like again, the minute you release that plank, if you're holding it, your blood pressure goes very, very high. So caution is warranted in anything that where you're now doing something isometric for, greater than 30 seconds, 40, 50, 60, and holding it for 5. When you release that aorta is vulnerable because there's a very high blood pressure. That would worry me, because that's that scenario where I showed, where I modeled, where you might have a normal thick aorta, thickness of the aorta, but you get that sudden surge, 240. That's not uncommon after this phase 4 Valsalva. So those kind of things worry me if you're holding your breath for prolonged times, because when you release it is when you're potentially in trouble. But rhythmic, Tai Chi, yoga, that also is going to have favorable effects on your heart rate, your blood pressure control. So those are always good.
All right, aortic athlete David, Dr. Molson asks, and okay, these are, I said crazy weightlifters earlier. We have even crazier ultra runners who have various kinds of aortic disease. Some have recently been repaired. No syndrome, no family history, the pretty good future, I think. But he asks, how long after open heart surgery to repair an ascending aneurysm will it take before I can run a marathon?
So it's a great question, and I always find it interesting because like it's when in the rehab program we have a very large cohort. We have a big aortic center here in Vancouver, and a lot of them come through our cardiac rehabilitation program after cardiac surgery. And a lot of people either had done that before, but it's surprising how many people after they've had surgery decide they want to run their first marathon. I always find that to be quite interesting. It's great. I think that's, we always want to be supportive. So what I would say after any sort of the aortic or any cardiac surgery, when you've had a sternotomy, there needs to be obviously a time to recover. Usually we don't admit people into a standard cardiac rehab program until usually 4 to 6 weeks. There's some evidence 2 weeks, but at that point you're really kind of still having to have a lot of precautions. So 4 to 6 weeks starting into the cardiac rehabilitation program. I would encourage anyone who's had an aortic repair to seek out a cardiac rehabilitation program because there's a lot of benefit to that just around some general recommendations, athlete or not. And then, so the guidance, it's still, again, it's all expert opinion. If the repair has been for an aneurysm, there's not any residual disease, non-syndromic, and that's something someone wants to do, over the next few months, usually I will have that discussion with them, and it's not unreasonable to have that discussion around going back to that type of physical activity. Again, always individual discussion, but it's moved a little bit to saying that that is something that can be considered. But what time frame you're doing that, the way at least I do this, and it's not everybody, is I kind of explain to everybody that if you've had open heart surgery, 3 to 6 months at least of kind of recovery for that, for whatever the reason is. And then if things go well and that's what you want to do, then usually another 6 months or so of continuing to ramp up your intensity after that, but really planning for some point 6 to 12 months before you're going back to whether it's a marathon, whether it's anything along those lines, just to give some time to improve and heal and adequately train. And use the analogy, if you wouldn't go back, if you had any type of injury, you need time to heal, and the heart and the chest need time to heal from that. And so it's not that, I obviously speaking to the group where everyone is well versed in doing these type of things, but from a practical standpoint, I usually would say after surgery that attend cardiac rehabilitation and see where it goes. And usually it's individual, but we do have lots of patients that have gone back to doing things like that. And I'm sure there's tons of patients on the call, yourself included, who have gone back to doing a lot of those things. Yeah.
And do you, aortic athlete Stephen asks about, he says doing 50 Ks ultra, wearing out bovine valves. I don't know. I haven't heard anything about that. What do you guys think?
Yeah, that has been raised in terms of increasing the shear stress on the valve itself as potential, or theoretic at least, for increased rates of degeneration of the valves. I'm not aware of any specific data in a sense that has clearly shown that, but it is something that we do, that has been, some caution is warranted, I would say, as we just don't know the answer to that. And with the theory being is that kind of increased cardiac output, increased shear stress along a non-native valve may potentially increase the risk of degeneration. But with most things, it is really just around monitoring and understanding that risk might exist. But unfortunately, it's another area where we just don't have a lot of great data.
Professor Akowski, aortic athlete John asks, can people exercising as little as 120 minutes moderate aerobic activity per week also have larger adapted aortas? I think he's wondering if his aneurysm was caused by moderate, lower levels.
Nate has made a really good point previously. Like, for the heart to remodel physiologically like an athletic heart, it takes quite a bit of volume. So in my opinion, I would think that moderate intensity, sort of 120 minutes, is likely not enough of a volume load to cause an aorta to remodel. Because although Tim Churchill's data showed that 20% of those elite athletes remodeled, that means 80% did not. And what's unique is that young athletes who've trained very hard at a young age, their hearts will remodel, but their aortas do not. So I'm sort of a belief that sort of in an everyday type of person, you've got to be doing quite a large volume of training to make that aorta remodel. But again, if there's some underlying pathology going, that may not be the case. But really, when we start talking about physical activity versus exercise, and remember, that could be gardening, it could be walking your dog. That type really isn't that much of a volume load where the aorta is playing catch with the stroke volume of the heart. So I would think not, but again, nothing's 100% in science. But generally, that's likely. I only say that because that type of exercise and all the studies we've ever done won't remodel a heart at any age.
So opposite side of the coin from aortic athlete Michelle, this will be our last question. I've had 3 open heart surgeries post dissection and have a 6.2 descending aneurysm. How can I safely work out?
Yeah, that is, I mean, I hesitate because it's hard to give. That's a lot. That sounds like she's had a
Complex case.
A complex case, and we have several or many patients like that as well, and we obviously want to do our best to support some degree of exercise. I would say that if you're interested in doing that, working really closely with your doctor, and that the message as well for anyone listening to the call is, I think what had sometimes happened in the past is that it's been dichotomized to don't do exercise or exercise. And then it's been a more of restricted or eligibility discussion when we've seen patients. And what we've tried to do is that there's a gradation of exercise here. And I think the newer guidelines, as Mark had highlighted, like doing physical activity that can gain benefit. Most patients can do some degree of light to moderate intensity physical activity. But in quite complex cases, that does need to be monitored closely. And, personally, we do a lot of these complex cases in our cardiac rehabilitation program, if that's an option, just to get that individualized advice. But there's not a clear-cut answer I can give without knowing more of the details there. But I think the take home is, really do want to encourage everybody to have some degree of physical activity for health and wellness benefits. But in complex cases, it really does have to be individualized with your provider.
When we surveyed our aortic athletes and asked, what is your primary means of exercise? I think 30% said walking.
Yeah, that's perfect, right?
Yeah.
Because for the general population, right, because we've engineered physical activity out of our life, right? No people, I go to the American Heart Association or I go to Oiler hockey game, everyone's taking the escalator up, no one walked the stairs. A week later, I went to the American Heart Association. All the cardiologists are taking the escalator. No one walked up the stairs. So even some is better than none. So just moving is still being active for the whole population for cardiovascular benefits. That's phenomenal. Now, does that mean the aortic athlete who's doing 50 Ks a day or whatever, that walking is probably not going to give them the training load they need? But walking at a self-selected pace is just great because you're being active, because not everyone is going to run Boston or New York like you, Jack. But it is funny, like Nate said it, because one of our transplant recipients said, "Oh, you're kind of a hypocrite. You preach exercise and you're short, you're fat." And he's like, "I'm going to outlive you." And I said, "What do you want to do?" He goes, "I want you to run a marathon." So my first thing was a marathon, right? That seems to be the entry level. But I think supervision is the key in those complex cases, because when you look at those graphs that I showed, larger diameter aortas, a minimal pressure does generate a lot of wall stress. So we have to be cautious and have good supervision.
I did my retirement marathon in New York this past November for the John Ritter Foundation. And my
Yeah.
average heart rate over 6 hours, 6+ hours, was 111. Those darn beta blockers did me
Yeah.
in, you know, but
Yeah. Yeah.
but I did it. Hey, listen, guys.
The good thing
Yeah.
about exercise, though, is I know we're talking about a little bit of hearts and a little bit of aortas, but when you're talking about fitness, fitness is your ability to breathe in air, heart will pump that oxygen through the vasculature, including the large aorta, but small vessels, and then the skeletal muscles. So I've worked with heart transplant recipients who've done the World Championship Ironman. Now their pump might not be as efficient as yours, Jack, but their muscles utilize oxygen. So the thing about just walking is that you increase blood flow to the muscles, and the muscles will use oxygen better. So yes, walking is great because maybe you don't have the best output of blood to the muscles, but they will use oxygen better. So the whole cascade of oxygen isn't just an aorta and a heart. It's also the vasculature and the muscles. So the whole system adapts with even walking.
Well, Professor Akowski, Dr. Molson, you are now friends of aortic athletes, friends for life, and we do want to have you back when you do that study on exertion on lifting in the MRI. Where I can tell you we'll be selling tickets to some of our members who are going to want to see you. But thank you guys so much. Thank you for your work too. You know, this is we're a subset of a subset of a subset, and we really appreciate. It really means a lot to our group that of what you guys are doing. So thank you.
Yeah, I think it's really important because I'm sort of one of those people that's like, when they say, well, you can't do that, I'm like, but what does the science say? And I value expert opinion, and it's really critical. But it's like, it's okay to challenge expert opinion, though, to say, well, let's measure that and come up, right? Because it may help the aortic athletes, individuals with aortic disease. So I like to add science, especially to areas where there isn't some, so we can, increase the knowledge in an area where there's uncertainty.
All right, Dr. Molson will give you the last word.
Yeah, no, I think that would be I echo that. I think that's why I quite enjoy working in sports cardiology. And I think, the aortic athletes and my aortic patients inspire me all the time. For those that just say they won't, I love your slogan, don't quit, adapt. That's just one thing that I pointed a lot of my patients towards your organization as well. And I think they found they're always looking for something, because I think, like you said, it's not necessarily the most common disease, but it's obviously life-changing. And that's, why sports cardiology exists, is patients are looking for these questions. The answer is that there hasn't been as much science in. And so I think it's a real pleasure to be able to kind of push some of that forward, and just excited to keep working in the space, and, appreciate the opportunity to hear and speak to your population.
All right. Well, thank you guys. Thank you. And thank you for watching, and we'll see you next time. Good night.
Sounds great.